So this is GBS, Guillain-Barre syndrome from Notes and Notes edition, fourth edition by Hamad. What's the definition? Immune-mediated demyelination of the peripheral nervous system, often following an infection like Campylobacter jejuni or cytomegalovirus. So it's basically an immune-mediated causes immune-mediated, and this basically demyelination of the peripheral nervous system, and it's usually followed by an infect. When it happens after an infection. Pathogenesis is basically cross reaction of antibodies with ganglioside in the peripheral nervous system. So this is the cross reaction is causing the demyelination. And anti-GM1 antibodies found in 25% of the patient. What are the characteristic features? Progressive symmetrical limb weakness, usually ascending pattern, starts from the lower limbs and go up, and affects proximal muscles first. Mild sensory symptoms are there, like distal paresthesia, areflexia is there, cranial nerve involvement like diplopia can be seen, bulbar involvement in 50% of the patient, risk of aspiration and respiratory insufficiency, autonomic dysfunction, urinary retention, and muscle wasting in the prolonged cases. Less common findings can be papilloedema due to reduced CSF resorption. So how do we understand if it's GBS? Firstly, clinically, of course, you will see the things that are said over here: symmetrical limb weakness, and there will be a history of infection. And other investigations can be CSF analysis. In CSF, you'll see elevated protein, normal glucose, no pleocytosis like protein peak in second and third week. Nerve conduction studies shows demyelination. This can be diagnostic. MRI used to exclude spinal cord lesions or other neuropathies. And usually the first line is IVIG, as effective as plasma exchange, fewer side effects. Instead of IVIG, plasma exchange can also be given. Steroids are not beneficial, and respiratory monitoring it is a must because the respiratory muscles can be very weak and might cause bigger problems. Regular FVC assessment. If FVC is less than 1 liter or 15 ml per kg, indicates mechanical ventilation needed. And rising PaCO2 is an indicator of mechanical ventilation, so you need to do a regular ABG to find out the carbon dioxide. And prognosis is basically 20% of patients may have permanent disability, 5% mortality. Okay, what are the poor prognostic factors of GBS? If its age is more than 40, then poor upper limb strength, history of diarrheal illness like Campylobacter jejuni, high anti-GM1 antibody titers, or need for ventilatory support. All these are poor prognostic factors. And contradictory contradictory evidence exists on whether gradual or rapid onset impacts prognosis. Okay, the next part is Miller-Fisher syndrome. It's a variant of GBS, and three symptoms are there like areflexia, ataxia, ophthalmoplegia. And the association is with ophthalmoplegia, areflexia, and ataxia. As I said, the eye muscles are typically affected first, so it starts from the top rather than from the bottom, and usually presents the descending paralysis rather than ascending, as seen in other forms of GBS. And anti-GQ1 antibodies are present in 90% of the cases. There is anti-GM1, this is anti-GQ1B.